Anybody here who works for an FQHC? Me? You? So
they're all learning about financing.
yeah, right. My name is Brenda Goldstein. I'm with Lifelong Medical Care. We're an FQHC serving northern Alameda County, Berkeley, Oakland, as well as West Contra Costa County. And I'm here with my partner at Alameda County Behavioral Health, Tom Trabin, to talk about a pilot that we have embarked on in Alameda County over the last year. And I'm also the chair of the Behavioral Health Network for the California Primary Care Association, where we're really looking at ways that FQHCs can partner with other organizations and in the effort to really create the best system of care for consumers around providing mental health services as well as primary care in an integrated model. Am I going to get my, oh, I have to do it? Aha! You learn something new every day. So first, I want to thank Tom for inviting me. I think he's really modeling collaboration by inviting an FQHC to share some of his 15 minutes. That's very generous. I really want to talk to you from my perspective. I want to talk to you about what it's like as an FQHC to be coming together with the county behavioral health department to do this work. Tom's going to talk about more of the nuts and bolts of the project that we're working on, but I don't think that you should underestimate the difference in culture between an FQHC and a county mental health department. And don't underestimate the ability for us to come together and work together, but it is not easy. And there are significant differences. We really are focused on primary care. We serve thousands and thousands of patients. We have hundreds of visits in a day. We have unique staffing and billing requirements. We're very fast-paced and productivity-oriented. We have histories of doing panel management, quality improvement, primarily on the primary care side. And we serve a lot of uninsured folks. And we also have a real broad range in terms of our experience with integrating mental health and primary care. Some of us have done a lot to develop that, and others are really brand new in this field. Whereas on the county side, I think you know what you do on the county side. I don't need to go through all of these bullet points in the interest of time, but very, very different cultures coming together. In Alameda County, there are eight FQHCs representing 26 different sites that are participating in this pilot. As I mentioned, very wide variation in integrated care experience. We, for example, have psychiatrists embedded at all of our primary care sites. We have, I think, 19 or 20 LCSWs working with us and a psychologist. Others have just started to hire their very first mental health licensed staff. Big difference in skills and the development of the use of IT tools, whether that's an electronic health record or registries. And some of our FQHCs actually do operate specialty mental health programs. Others of us have not been in that business at all. So quite broad range of experience and orientations and history of working with county behavioral health. The reason that we included this slide was to give you a sense of who the FQHCs are in Alameda County who are participating in this, not so that you know every single one of them, but that you can get a sense for the range of the diversity of populations served by FQHCs and the benefit of county behavioral health departments and other mental health and substance use CBOs partnering with the FQHCs. We have tremendous penetration, trust, good relationships with a lot of different communities, whether it be in Alameda County, Asian Health Services, in Chinatown, and in other neighborhoods serving a broad range of Asian communities. La Clínica de la Raza, our Native American Health Center, also geographic coverage across the county. And with that, I'm going to turn over the presentation to Tom.
Hi, and then later on, I'm going to turn it back to Brenda.
I get the last word.
I think it's very important as counties to be, on the one hand, good custodians of the dollars that are flowing through us to fund these projects and to set certain parameters. But on the other hand, to have a deep sense of humility. We're not the experts when it comes to what life is like in the FQHC setting, and to be good listeners, good collaborators, good communicators. And I thought that also the medium is the message, and for both of us to be presenting conveys that sense of collaboration that's so important. So the impetus primarily for this project was the Bridge to Healthcare Reform, we had to make a commitment in exchange for the federal dollar matches for our LIP that we would provide access to a wide range of services, including for mild to moderate mental health conditions. And so the question was, since we in our department were so well poised to do that for folks with the more serious mental illnesses, where and how do we build that capacity that we once had a long time ago? And we all agreed that it made best sense to build that capacity in the primary care clinic, which most folks who have mild to moderate conditions in this country go to anyway, and best to catch it there and build that capacity there. And that also foresaw the directions that healthcare reform is going. Our purposes were not just to build that capacity, but also to reduce stigma and to be able to get better care for some of our clients with serious mental health issues who needed primary care, and to have good services in those clinics. Let's see, so okay, in order to leverage it for the startup. So we had some money that was in the form of funding for technical assistance to a major national consulting and training firm with a model for integrated care. And we picked, in concert with the primary care clinics, who were given a choice of several, and ended up opting for the AIMS Center in Washington. We also had some money to help the clinics hire behavioral health professionals, and we had a formula for that based on the number of uninsured they had been seeing. And then we had another pot of money for pay-for-performance contracting to support and encourage the implementation of integrated care, and some money to hire psychiatric consultants. And we also had some money from the agency, healthcare service agency level, to make sure that folks at the clinics are reimbursed for providing certain CPT codes that have to do with mental health and substance use interventions. So the motivation for this, as the balance to what Brenda explained as the different cultures, what we had in common was we had a shared interest in building capacity within the clinics for this integrated model. If you haven't already, if you check the CMS site for what kind of conditions qualify for membership in a healthcare home, you will see mental health and substance use conditions as among the chronic ones that qualify. So those people, the FQHCs, who want to be accredited as healthcare homes need to build that capacity anyway, and so they have a strong interest in it. They also had not been typically coming together as a group to talk about how they were building this kind of capacity, and this project helped provide the impetus for that. So there's a lot of gains on both sides, a lot of mutual interest, and of course the key beneficiaries, most importantly, are our population being served in Alameda County. The AIMS model has several principles to it. At its heart is team-based care. So the behavioral health professionals in the primary care clinic are primary care providers in the sense of this is the first stop for people, and the behavioral health professionals are just another part of the team that plan together, that discuss different kinds of patients' problems together, and they work closely and collaboratively together. The AIMS model distinguished itself from some others in that they encourage strongly that a subset of people being served be included in patient registries with prompts based on the evidence of what works for follow-through. And I'll talk more about that in a while. Some of that follow-through also involves giving measures repeatedly to see whether a person is progressing or not. And if they're not progressing, then the behavioral health professional is supposed to try something new. It is accountable care in that there is a heavy use of data, not only for quality improvement of care within the clinics, but for showing that, in this case, to us as funder and the consortium of all these clinics who collect the data and then report it in summary statistics. And it makes use of consulting psychiatrists when folks get stuck at the primary care clinic level and need some extra advice about what to do. The levels at which care can be delivered in the clinics are varied, and you can read this in the slides that you have. But I think what I want to mention is the primary care doc can just provide some intervention or medication, or they can call in the behavioral health professional for an in-exam room one-time consultation. However, for a certain subset of patients, the behavioral health professional can decide to put them in the registry and provide a several-month focused evidence-based practice follow-through care. And that's really at the core of the AIMS model. When they get stuck, they can ask for psychiatric consultation, or then they can always refer out to specialty behavioral health. And we have a whole set of protocols for this. In stage 1 of payment, 60% of all of the funds that are allocated to an FQHC can be received by them and used to pay for a licensed or almost licensed professional. We want this to be financially sustainable, to hire these folks, train them, and get them started in billable services. The other 5 stages are in a fairly elaborate pay-for-performance schema that includes rewards on a quarterly basis for the extent to which the clinic has enrolled people in the registry, has a % of those folks in the registry who have been followed up at least twice a month by phone and or in person, a certain % who have received psychiatric consultation, a certain % whose records have been reviewed for medication, and also a certain % who have achieved a certain level of progress in change scores in the monthly administration of the measures. The measures are, let me see, we also want folks to engage as professionals in evidence-based practice training. We are launching 5 year-long trainings starting next month, and those are for problem-solving therapy, motivational interviewing, seeking safety, which is for PTSD, SBIRT for substance use, and CBTI, which is for insomnia. The trainings go for a year because we know that a one-day workshop really doesn't act to change clinician behavior. And the measures that are being used, you can see the PHQ-9, GAD-7, the PCL is for PTSD. The UNCO Plus is a somewhat modified measure for screening and for progress with substance use that we've been working on, and the ISI is for insomnia.
So these are some of the questions that ran through our head as we were having the discussions about implementing this pilot project. From the FQHC side is, does the county really understand the challenges of providing services in a primary care setting? And what they're asking us to do feels pretty daunting. We're willing to try it. We need to be able to come back to the table and say, this is working, that's not working. Come see what it's like for us to try and do this in a primary care setting with all the pressures that we have. When the AIMS project was first introduced, they have their own standalone registry, and we just looked at it and said, no way. We're trying to get an EHR up and running. We're using eye-to-eye tracks. We cannot possibly use another data system. And you can't possibly expect that from us. So there's been a lot of give and take on that area as well. We had to ask ourselves whether we were really willing to be accountable for outcomes on the behavioral health side. That's something really new for our behavioral health providers. We've gotten used to it on the primary care side, but not on behavioral health side. It's also very challenging for us as FQHCs to recruit behavioral health professionals. We're in competition in terms of salaries with counties and with prison systems, and it's very difficult for us to find find behavioral health professionals who speak languages other than English, and that's where a lot of our demand is. So some of the clinics have had some real challenges in getting staffing up and running. And then finally, and I think this is an ongoing issue, which we'll probably be talking about next month, is how do we pay for the amount of administrative work that it's really taking us to do the kind of tracking, reporting, et cetera, that this kind of a pilot is requiring, and how sustainable is that over time for us, and how do we manage that? So in the spirit of Valentine's Day, I figured I call this couples counseling, is that, you know, we really want to keep our eye on the prize, which is long-term system change. And this is one-time funding. How can it be used to really promote permanent system change and movement towards the systems that we know are developing with the Affordable Care Act and with movements in the mental health system as well? And can we really listen to each other and be willing to give up and adopt and adapt to each other? It's been extremely helpful to have money on the table. That has certainly motivated us as FQHCs to participate. I applaud the county for being creative in finding some money to put at the table, both through our LIP and in some creative use of the MHSA funds. And then we spend a lot of time talking to each other and in meetings and back and forth with emails, and like any other relationship, that makes a huge difference and has brought us as far as we are today, and hopefully will help us to continue to really develop this into a project that provides expanded access and a real system of care for people along the whole spectrum of need in terms of both mental health and primary care. Thank you.
Thank you.
Our contact information is in your packet.